Hi everyone. My case today is over what I titled like the hidden nutcracker syndrome. So I first saw this pathology during my clinical rotation. It was my first site to be exact, and it completely amazed me to watch like the preceptor know exactly how to look past a simple local symptom, avoid tunnel vision, and trace the real issue up into the abdomen. Today we are going to look at this case exactly and know like how a sonographer uncovers it step by step. So the rationale for reporting this case is centered on the definition of Nutcracker syndrome, which is, as we know, like the mechanical compression of the left renal vein between the SMA and the aorta. Its clinical significance is huge because it acts as a hidden underlying cause of secondary testicular varicoceles in young patients. So I selected this topic because of that amazing experience I had in clinicals, as I mentioned before. It proved to me that as future sonographers, our ultimate goal is to look at the bigger picture and connect localized gonadal venous flow directly to the larger abdominal tracts to find the true root cause of a patient's pain. Looking at our disease background and pathophysiology, there are two main types. So there's like an anterior nutcracker, which is where the left renal vein is trapped in an acute angle between the aorta and the SMA. But there's also a posterior nutcracker, which is where the vein runs behind the aorta and is crushed against the spine. So mechanically, the tighter that anatomical pinch is, the higher the pressure becomes, forcing like blood to back up all the way down into the scrotum. This heavily affects low BMI teenagers because they lack that retroperitoneal fat pad that normally cushions these vessels. So let's review like the clinical presentation from our case report. Our patient's a 14-year-old male who presented with a chief complaint of sharp, glass-like left scrotal discomfort. On physical examination, he had left-sided scrotal aching and a highly visible swelling. This varicocele became significantly more prominent when he was standing up or performing a Valsalva maneuver. Before his ultrasound, he did have an MRI that had just been ordered just to check out like the general testicular discomfort. So during the scrotal ultrasound, the sonographer confirmed a severely dilated left gonabitrusating papiniform plexus. But we know this is like an isolated severe left-sided varicocele in a young, thin guy. So knowing how the anatomy drains, where is this backup coming from? Like, based on what we just went over in the introduction, who remembers the exact name of the abdominal vascular pinch that squeezes this pathway upstream? It's the Nutcracker syndrome. So now that we've revealed the answer, let's look at why it happens. While a severe left varicocele can sometimes be caused by things like retroperitoneal tumors, which isn't the case in this specific patient's, but it's something that can happen. In this patient's case, it's more like a plumbing per se issue, we could say. The left renal vein is tightly compressed in the narrow angle between the AO and the SMA, and this massive pressure backs up down the left gonadal vein, and it's like blowing out the valves in the scrotum. So if we move the transducer up to the abdomen, it's gonna reveal where the left renal vein is crushed, narrowed. To efficiently diagnose it, the vein's width must measure at least 4 times larger before the pinch than inside the pinch. More importantly, your spectral Doppler will show blood flow shooting through that narrow gap at least 4 times faster than normal. So these velocity shifts are most extreme when the patient stands up because the gravity tightens the vessel angle. Our differentials include a primary varicocele, where is when the tiny valves inside the scrotum fail, or like a tumor's pressing on the lower veins. We rule those out by proving the specific blood speed changes inside the left renal vein. Treatment can be simple, like it can be simply just waiting. Sometimes gaining weight helps that because it like grows a fat pad that naturally opens the vessel angle. Other times, doctors have to put in a snare, like perform a gonadal vein transposition surgery. So in our case, the patient returned a month later for a formal renal study and was referred to like a vascular surgery for like a follow-up. The left gonadal vein drains into the high-pressure left renal vein while the right drains into the IVC, explaining why Nutcracker only causes left-sided varicoceles. Second, watch out for thin, low BMI adolescent patients on your boards because they lack that cushioning retroperitoneal fat pads. And finally, Always check left renal vein velocities in both supine and standing positions, as the ratio will drastically accelerate when standing. So clinically, this pathology completely changes your scanning technique, I would say. The moment you find a severe isolated left varicocele, you should also start taking differentials into consideration. The additional images you need to obtain include full grayscale, spectral Doppler, color, sweeps of the left renal vein in both the supine and standing positions, along with views of the left renal vein sweep. And finally, you must immediately communicate the critical findings to the interpreting physician, specifically reporting like the left renal vein diameter ratios, the massive velocity spikes, and the severe retrograde like scrotal flow reversal. In conclusion, if a young male presents with a severe left-sided varicocele, consider what may be causing it. Always measure and report the left renal vein diameter and velocity ratios to the radiologist. Like, communication is key. And look at the bigger picture. The root cause of small parts pain might be hiding right in the abdomen. So then, yeah, here's my references. And thank you.